We are live, ma'am.
Thank you. Yeah, good evening, everyone. And it is my privilege to welcome you all to today's workshop of No Thrombosis KT Live, which we call. And the objective of this workshop and this session is to bring the leading interesting neurological cases across Pan India on this platform. And it is really very important that, such real world insights are important to be displayed because they play a crucial role in advancing our clinical approach and improving the procedural strategies and ultimately enhancing and advancing the patient care. So, today we are truly honored to have the expert group of panelists on board to discuss some interesting cases related to this. So let me first introduce our course director, Dr. Meenakshi Sundaram, who does not require an introduction, but let me do the honors. So, Dr. Meenakshi Sundaram is a senior consultant neurologist at Apollo Specialty Hospital. He has done extensive work in epilepsy, movement disorders, neurorehabilitation, and various other things. He has also contributed extensively to multiple research papers, case reports, reviews, and has also done significant work in Wilson disease, stroke, epilepsy. He is editor and contributor to leading neurological textbooks also, and he is gold medalist at the best outgoing student. So we are really very honored to have you today as our course director. Moving forward, let me
Thank you,
introduce
Namaste, madam.
none other than Dr. Balam Murugan, who is the moderator for today. He is a senior neurologist, currently director and consultant neurologist at SIMS Hospital, Salem. Sir is MBBS MD DM neurology. And sir has extensive publication, that is 25 plus publication in PubMed Research Journal. And he's also contributed to Practical Neurology and De Jong's Neurological Examination. And sir has 100 plus guest lectures at national and international conferences. He is also post director fellowship in neuro emergencies and chairman at API Tamil Nadu. Sir has got various honors, awards, and affiliation to his credit. So welcome on board. We are really very honored, and it was pleasure introducing you. It gives me an immense pleasure to introduce our next moderator, Dr. Balakrishnan, who is MBBS, MD, DM, DNB Neurology. He is professor and head Department of Neurology, Hospital Coimbatore, and with over 16 years of experience in neurology. He holds the prestigious international qualification, including MRCF, Neurology UK. He is a recognized academician and educator and actively involved in teaching undergraduates, postgraduate students. He holds a special interest in stroke, epilepsy, headache, and various movement disorders. He is author of numerous national and international publications, and he's active member of various neurological society, to name a few, including Indian Academy of Neurology, Indian Stroke Academy, and Stroke Association, and American Academy of Neurology. We are very honored to have you, sir, as a moderator, and looking forward for the insightful discussion with you. Next, it gives me an immense honor to introduce our esteemed speaker for today, Dr. Deepa ma'am, who is a senior consultant neurologist with expertise in stroke, neurorehabilitation, headache disorders, neuro-ophthalmology, multiple sclerosis, epilepsy, movement disorders, and cognitive neurology. So, ma'am is former associate consultant, assistant professor of neurology at Sri Ramakrishna Medical Center and Medical College, Chennai, with extensive experience in clinical practice, teaching, and research. Dr. Deepa is also contributor to renowned neurological textbooks, including De Jong's Neurological Examination, Practical Neurology, IAP textbook of medicine, and Encyclopedia of Neurological Sciences. She is also author of multiple peer-reviewed publications in various leading national and international journals. and she is the active member of American Academy of Neurology, Indian Academy of Neurology, and Indian Federation of Rehabilitation. We are very honored to have you, ma'am, and we are really looking forward for the interesting case which you would be presenting today. Next, let me introduce our esteemed speaker, Dr. Narendran, who is MBBS DNB DM Neurology and and presently working as a consultant neurologist at Meenakshi Mission Hospital and Research Center since 2021. He is instrumental in establishing South Tamil Nadu's first comprehensive epilepsy monitoring unit and pioneering epilepsy surgery services, including respective and palliative procedure. He holds expertise in stroke, epilepsy, migraine, neuroimmunology, movement disorders, pediatric neurology. He has got extensive experience in advanced therapies for neuroimmunological disorders, including the use of monoclonal antibodies with a strong focus on patient-centered neurological care. He is recognized for diagnosing and managing rare neurological disorders and for contribution to developing innovative neurological treatment protocol. Sir is also actively involved in mentoring junior neurologists, advancing epilepsy care, and enhancing neurological services through his clinical excellence and multidisciplinary collaboration. We are really very honored to have you, sir, today and looking forward for the interesting case. With this, without further delay, I would like to hand over today's session to our esteemed host director, Dr. Meenakshi Sundaram, and take this session forward. Sir, you're speaking on mute, sir. You need to unmute.
Thank you very much for the kind introduction, Dr. Shrutan Madam. Let's straight away get on to the business end of this meeting. And I'm very excited to listen to two wonderful people, Dr. Deepa Madam, with whom I worked closely during our project on Jose Biller's, editing work on the Southeast edition. Very happy to be seeing her after a long time. And then Dr. Narendran, whom I know is a brilliant neurologist, the go-to person for me. When I have difficult cases in my clinic, I straight away write a letter and ask Dr. Narendran's guidance, and he really guides me in all my cases. So two exciting people, and then my course directors, my colleagues, Dr. Balmurugan, my teacher, and Professor Dr. Balakrishnan sir. Let us open the session after the opening words of my colleagues, Dr. Balakrishnan sir and Balmurugan. Thank you. Balu and Balmurugan sir.
Balakrishnan sir. Balakrishnan sir, please proceed.
Sir, நீங்க பேசுறீங்க சார்.
Yes,
Okay.
let speakers start the presentation. Nothing. No.
Yes,
no.
sir. Yes, sir.
Sure. Yes, first presentation is. Let's move the first presentation. SMS.
Please, let's take forward the first presentation. I think Dr. Narendran, you are going to go first.
Yes, sir.
Opening
sure.
back. Yeah. Thank you. We're waiting for your talk.
Thank you so much for the introduction, sir. Modest as always. Sir, this panel, as I see, it suddenly felt that I'm presenting in Nimmans Saturday because all senior neurologists from Nimmans. So I am a little bit very tense because it is bringing back memories of Nimmans. So I'm presenting a very rather simple and straightforward case. Previously, I have not presented on this forum. I don't know what the usual procedure is, but recently I came up with a patient who had a very straightforward case of a stroke, but had very difficult course of the disease, and I had no other way or no other option than to slowly witness the progression of the disease in spite of all we did. So I'll straightforward start the patient's presentation. Just give me a minute. Is the screen visible, sir?
Yes, sir, it's visible. You just need to do it on presentation mode.
So good evening, everyone. Today I'll present a simple but straightforward patient who presented with acute stroke. And this patient made me wonder whether we can do anything different in managing stroke, because throughout the entire course of the disease, I was a silent spectator because I was not able to do anything to prevent the progression of the influx. So I thought I'd discuss this with seniors so that I can learn what I could have done better or what I should have done differently. So coming to the patient, he was a 72-year-old doctor. He came with sudden onset right upper limb and lower limb weakness and global aphasia. The symptom onset was on 12th April of 2026 at 5:30 a.m. He arrived at our emergency department at 7:10 a.m. Admission in NIHSS was 21. He was completely aphasic. He was not responding because of the aphasia, and he had right upper limb and lower limb weakness, and his NIHSS was 21. So we suspected stroke with involving the left MCA territory, and immediately shifted for imaging at 7:55 a.m. This was the initial MRI and CT. We have a protocol in our institution where we do DWI flare and CT angio. Immediately a patient comes with stroke. So this was the DWI findings. You can see that there is a deep watershed, small acute division restricting lesions involving the anterior and posterior part of the frontal and the temporal lobes. This is the MRA. You can see that there is a long segment hyperintensity in the left MCA, suggestive of an acute thrombosis. And CT angio was showing probable complete thrombosis of the left ICA. And coming to the pattern of the influx, it was giving a suspicion that there was an underlying ICA chronic stenosis, superadded to which there is a acute thrombus or emboli. So we started discussing about the thrombolysis with the patient family, and then he was immediately thrombolized with injection tenecteplase, 20 milligram at 8:15 a.m. And the interventionist opinion was sought. So after interventionist saw the MRI and the CT angio, he was really skeptical about the nature of the occlusion and the extent of the thrombus, and he was not very confident about the outcome because of the length of the involvement of the clot in the left ICA. So with the patient's family, we discussed that the influx size is very less and the occlusion is very large, and the risk of bleeding and the risk of the outcome may not be very different after thrombectomy. So the patient's family deferred mechanical thrombectomy, and then he was shifted to a stroke ICU, and his GCS at the time of admission into the stroke ICU was responding to localizing to pain, and he was aphasic. Day 2 of admission in stroke ICU, the patient was monitored closely. There was no worsening of weakness or drop in sensorium. He was started on dual antiplatelets after repeating a CT which showed no bleed, and he was started on high-dose statins and anti-edema measures. BP was maintained well above 150/90 because of the acute involvement of the left ICA, and blood glucose levels are maintained below 200 milligram per deciliter with insulin. On day 3 of the admission, patient and 4 of the admission, patient had spontaneous eye opening. He was briskly localizing to pain. He was aphasic, and pupils were equal in reacting to light. No change in the clinical picture whatsoever. So we were continuing the same treatment. On day 5 of admission, there was mild decrease in sensorium. Still, he was localizing to pain, but he was not as briskly localizing on the first day. And he was opening eyes to mild pain and not spontaneously. However, there was no pupillary asymmetry and no further worsening of weakness or sensorium. This was the repeat CT on day 5. So you can see that the influx had progressed, and the areas of influx extended up to the right frontal and the temporoparietal regions, and the size had increased, but there was no midline shift or mass effect. So this repeat CT was done, showed progression of influx. There was a doubtful decrease in BP the previous night around midnight, the BP recording was about 120/80 and 110/70. So we thought that a small drop in BP triggered the progression of the infarct. So we tried to increase the blood pressures. We considered adding midodrine, and it was added, and the strict glycemic control was continued. There was no further worsening, and he was intubated effectively because of the worsening in the sensorium. Day 7 and day 8, we thought the patient will require a tracheostomy, and he underwent tracheostomy. He was still localizing to pain, but eye opening was little better than previous days. Day 9, repeat CT was done, and which showed a 10 mm midline shift. However, there was no drop in GCS, no worsening in clinical picture. So this was discussed in detail with the patient's family, that the infarct is on the left side, and since there is 10 mm midline shift, but there is no worsening of GCS, still decompression may be considered. But even after decompression, the patient's clinical condition, meaning the aphasia and the weakness, may not improve, and they may have to be taking care of him regularly. So decompression was discussed among multiple doctors from the family, and it was deferred. This is the infarct CT on the day 9, which showed multiple infarcts on the left side, now involving the ACA territories also, and also on the opposite side with a midline shift of 10 mm. So day 11, the patient's sensorium further worsened. Repeat CT showed a large midline shift. At this point, even the patient's family decided they should go for decompression, and the patient's family agreed for decompression. We took the patient for decompression. This was a CT on day 11. The CT shows a very large infarct, which is compressing on the lateral ventricle on the left side and pushing to the opposite side, and a gross midline shift of 21 mm. On day 13, after the decompression, this was a CT which showed complete deformation of the brainstem and a significant midline shift. And even after decompression, the patient midline shift continued to worsen, and the sensorium did not improve. So the patient's clinical condition continued to deteriorate. On day 15th of the admission, he developed hypotension and bradycardia. Despite all resuscitative measures, patient could not be revived and was declared dead. And even though this was a straightforward, simple stroke case, I left. Throughout the 13 days of admission, I was left with only discussing the daily CT reports with the patient's family, and I was not able to do anything differently, and except waiting for the silent spectator of the worsening of the CT and the midline shift. So I was asking repeatedly after managing this patient. These are the questions I asked myself. Would thrombectomy have really altered the course of the disease? Why did the patient continue to worsen the way he did? Instead of developing an immediate large infarct, why did the patient continue to worsen day by day, slowly over the course of the time of 2 weeks? And CT angio did not even show very poor collateral circulation also. Was it slow failure of the autoregulation or the collaterals? Or was it a shower of an artery-to-artery embolism continuously happening? If the patient had come after window period, how could we have managed differently to prevent progression? These were the questions I was asking myself repeatedly. And I thought this could be a simple case, but our seniors could highlight me what we could have done differently in this patient. Thank you. I request feedback or comments on this patient's management.
Thank you, Dr. Narendran. Very honest and straight presentation, as usual, as your style, really. So, Professor Balakrishnan sir and Dr. Balmurugan sir, your views, please.
Yes. Yes,
Sir, please, sir.
Please go ahead, Balakrishnan. Yes, sir.
No. Do you have the CT angio images from whether the ICA is blocked from the neck origin to the whole CCA and MCA, or how is the occlusion? the acute thrombosis or some atherosclerotic clots with the thrombosis? How is the like ICF?
CT angio showed an occlusion from the
Origin.
I mean, not from the origin, sir. It's from the bifurcation. Supraclinic segment. From there till the MCA, it was there, sir. From the
Extracranial ICF was okay?
Yes, sir. Extracranial ICA was okay, sir.
Okay. Did you use any heparin in this patient?
Heparin, we did not use initially, sir. Later we used after the clinical progress.
Okay. Because no, because though the guidelines doesn't say that we have to use the heparin routinely,
Yes, sir.
sometimes we see a lot of patients who getting admitted in our hospital. Initially, is showing a small infarct, then suddenly the infarct size increases and they just go down.
Yes, sir.
Mainly in the patients who have a large IC occlusions and MC occlusions, we have seen this kind of in hospital worsening of deficits, and we've come across many patients like this. But we routinely use heparin in most of our patients. But this, I don't know the maybe our Dr. Balamurgan's and SMS experience. I don't know their experience of in-hospital worsening with heparin and without heparin. But probably I can say that I'm using it for a longer time, and our like progression is somewhat. I feel it's less in the last 15 years I'm using. But still, we are seeing some patients who are on heparin, large IC occlusions, they tend to progress. And sometimes they bleed also. I agree.
Yes, sir.
And only thing I think which you would have maybe made some difference in the patient's outcome would be a mechanical thrombectomy. That's what we would see. Anyway, the patient is, see, you would never expected in the first day that this patient is going to worsen like this. That's
Yes,
why I think we didn't attempt maybe thrombectomy. But in a retrospect, when we put everything together, maybe at least a trial of mechanical thrombectomy would have saved this patient, or maybe go home with some deficits we don't know. In retrospect. So, but
Yes,
I
sir.
definitely agree with your way of approach and the kind of treatment you are given. But sometimes the disease doesn't go as like we like.
Yes, sir.
It actually acts differently, and sometimes we have very bad outcome.
The presentation might have been very simple, sir, but really, if you face the patient, actually, some patients come with IC occlusion, they develop an infarct very minimally, but next day or within 2 days, they develop an entire IC territory infarct and then they
Yeah,
worsen. But
yeah.
here, this was over a period of 2 weeks. It was slow progression over 2 weeks, and we actually, it was like I felt I was a silent spectator of the disease where I could not do anything and was slowly progressing over 2 weeks.
So
Uh,
do you have a collateral assessment in this patient? Does this patient had a good collaterals?
yes, he had good collateral, sir, but I could not get the images because of the PAX issue. But he had
Okay,
good collaterals, and there was no, it was not like very poor collaterals also. That is why I don't know why this patient wasn't. And heparin was considered because the possibility of an underlying ICA dissection was also considered. And then we added it, but there was no change in the course of the disease. I had some ethical questions also during this case. Actually, if we receive a patient and we have only one interventionist, and or a interventionist who is not very confident in doing this, what exactly we should do in that situation? Whether we should refer from here to the other hospital where an interventionist is present, or this was actually the problem in mechanical thrombectomy here, where the interventionist was not very confident enough to attempt the thrombectomy here.
So we had a few CC occlusions, and we had done a successful mechanical thrombectomy, and patients went home.
Yes,
At
sir.
least we definitely on follow-up they have deficits. At least the life is saved. The only thing is the family, even though left MCA, even though they're not talking, communicating, and at least they're seeing them alive. That makes them happy. But in the Indian culture, I think that's this thing. So sometimes when our intensivist on leave,
Yes, sir.
or he is out of town and is not available, we used to call the interventions from other hospitals.
Okay.
That is allowed from in our hospital. We can call any interventional radiologist from nearby hospitals. They're all in within 5 kilometers distance in our Coimbatore. So they'll definitely come and do the procedure,
Okay.
and they get paid. So there is some understanding between the interventional neurologist, some radiologist in Coimbatore. This is happening. This is a good thing.
Okay. If the patient had come after the window period, after we could not have done a thrombectomy, how else we could have stopped the progression of the disease in this patient?
No, I think I don't know, but
Cannot do.
DSA would have in the first day itself would have told us whether the dissection or
Okay.
not.
Okay.
And only thing I think I have a slight this thing whether heparin might have been whether beneficial or not. I don't know. I think we'll hear from Dr. Balamurugan and Dr. SMS their views on this patient.
Yes. In this patient, one thing it is a stroke, but it is a watershed infarct.
Yes.
So we are not bothered about the pathophysiology of stroke. The only thing that other than the hemorrhage or infarct, when you go for a thrombolysis, Narendra, an excellent presentation because very honest and excellent presentation. We come across, we don't present these type of cases because this demoralizes sometimes. That's the only thing that, and you are courage enough to present, and then we know thrombosis. First time, no thrombosis. It's a where the thrombosis is extending. It's going a lot. Watershed, yes, thrombolysis has been done, but one clue in the CT is watershed infarct. So that
Yes, sir.
tells us the pathology very unlikely. We can't say categorically it's not embolic. Still, it could be possible embolic. Watershed is more likely something sitting there and a critical stenosis is there.
Yes,
So
sir.
a careful on a BP, on a little bit of higher side of the BP will be first my concern. And probably you might have seen the CT angio, the extension of the um, thrombus. And in that situations, if they are not willing for empty, they are not willing for empty. That's all. We can't push them. If you have done for empty, again, the same thing has happened. You would have felt that uh, you have made the patient to spend more money also. The critical stenosis, where exactly happens, whether BP or careful monitoring of the BP or no antihypertensives or no anti-edema measures in the initial phase. These are the concern most of the time I do when the patient deteriorates, especially with a critical stenosis. And whatever the radiologist view after this patient, knowing that the patient is deteriorating, and can a vessel wall image help us to say it is an acute versus a chronic thrombus? And because you had one more differential diagnosis of dissection, whether it was a possibility you considered or really you had made the diagnosis by vessel wall imaging. These are all the things. Otherwise, when you could not help the patients in the postmortem period, we can also can't help that. Whether any clue from the um, angio from the arch, whether it is just the more and more thrombosis going on from the cardiac or from the arch of the aorta, any other clues?
No, sir,
Why
arch was normal, sir.
arch is
Arch
normal?
was normal. Yes, sir. We do
Okay.
always from the arch. So arch
Okay.
was normal.
No cardiac source.
Therefore, no cardiac source.
Okay.
As you said that my first concern was also to maintain the BP on a higher side because of the first I considered as soon as I saw the CT or MRI, I thought it is a critical stenosis of the left ICA and you'll be requiring left ICA endarterectomy or a stenting. But once I saw the MRI which showed an extensive left ICA hyperintensity, only then I thought this is an acute event that is going on also. So as I said, my primary concern was also maintaining a BPR on the higher side. Initially, we are not given any antihypertensives, but once we had one episode of 110, 70, 120, 80, and I used midodrine. I don't know what other people use for raising their BP. So that also I wanted to know from you, sir. If you want to keep the patient's BP on a higher side and without any antihypertensive, the patient's BP is on the lower side.
I'm particular about not raising the BP unless somebody has given antihypertensives. Only one patient had a fluctuating hemiparesis.
Okay.
So outside they had given antihypertensive and they have given sublingual and then they have given oral, but everything acted in the oral level. So that's one patient that I have to raise the BP with normal saline and not adrenaline. So,
Okay.
but it all happened within 6 hours, and then that recovered. So it was a fluctuation. Of course, the only one experience of. Otherwise, I'm more concerned about not giving
Reducing the
anti-ICU because a lot of multiple consultants involved in the ICU. Sometimes the cardiologist from their side they give, and I'm very particular about not giving any anti-edema measures like sometimes all stroke. So the people give mannitol and other 3% saline. So these are the two things I'm very particular about the watershed infarct because the pathophysiology is a little bit different. When a real of stroke, why it started with all start with a watershed infarct.
Yes, sir.
So for our understanding about pathophysiology, something is critical stenosis happening at the MCA level or at the ICA level.
ICA level.
Yeah. So wonderful case. Otherwise, we feel sorry for the patient, but what else can be done? Dr. SMS, final word?
There's no final word, Balu. He has not even reached the quarterfinal stage. Sir, I have some questions to just clarify. Was it a tandem occlusion or the single long occlusion?
It was single long occlusion, sir.
So there was no tandem, there was not a lesion here and above there.
No, sir. No, sir.
Yeah, that makes our life actually difficult, as I completely agree with you, because if it is a tandem, then there is a class 1 indication straight away, because that's what all these things, the MR clean data, all those data were done, all those data escaped, all of them were favoring those issues. But I agree with you that if it's a single long lesion, it is difficult to recanalize. But nevertheless, I feel, I'm giving gut feeling. Whatever you did is perfect because we have to live with our gut feeling and we will have different views. That's what neurology is all about, absolutely. So we completely agree with your line of management. But what I would have done is, as I told you, would have definitely opted for thrombectomy any which way. I would have gone ahead with this in this case. The long segment I would not have come off because the NHS is quite high and the aspects was quite low. These are two things which would have pushed me to do it. I would have pushed my endovascular person to do it. And the ethical question we asked, I have faced this ethical question. Let me tell you what happened. Some 15, so when we started, 2015, we started. Around a couple of years from then, we had a difficult situation when our interventionist was not in station. I got an interventionist to come here and do it for me. I've done that. But it was not successful. One of the reasons why I found out was that it is like playing in your home ground versus playing in a different ground, which you're not used to. You have a different set of technicians, different set of instruments, different set of, even that looks difficult. When you have a phone which you use now and then use another person's phone, you have difficulties, at least initially. And here the crucial aspect of time is a really constraint for it. It's a ticking time, it's a time bomb there. So therefore, after that, I learned the next case which happened, we shifted the patient out of the hospital. Here is one case where I put my foot down. Nobody comes in our way. There is nobody who can oppose us. Be the devil's advocate. I've done both these things. And I found the second is useful. Given the choice, I will shift him out. I will not hesitate. Go. That's my reason. We have done that in the past. That's the ethical answer for my side. But what I would have done is in the chronic occlusion, as I said, I would have really tried my best, though I know the success rate will be very less. That is the thing. But nevertheless, I would have attempted, I feel, in this case. That's what I have did differently. When you ask differently is why I thought over it. This is one thing. Acute tandem lesions. In fact, recently we had a patient who came with just a TIA. And we advised angio. Angio was done. And the angio showed a chronic IC occlusion. He came with TIA perfectly. So we offered mechanical thrombectomy. We offered stenting for him. We decided we'll go ahead with this. He was posted. The family took 48 hours. We also wanted that 48 hours. That 48 hours exactly it was closing and we posted the patient. Our interventional, there were two wonderful guys. I'm not blowing my trumpet. Our two interventional guys are excellent, Ravindran. I can place it on record for anybody to view this. Extraordinary people. There's one Dr. Santosh Babu and Dr. John. Highly ethical people, highly efficient people. These two. You can trust them for any future references you want. No blowing trumpet, just actual work I'm putting across. So we had posted this patient. These guys had posted at around 8 o'clock in the morning. So it was an elective posting. And mind you, 6 o'clock, the patient had a stroke. And now we immediately did the scan and it showed not only a chronic occlusion. Now there was an intracranial segment. The M1 was showing an acute thrombus. So we went in, endovascular, stent retriever, took out the clot from there and then placed a stent. and then dual antiplatelet, and the patient is doing excellently. Believe me, massive stroke, and this patient I've seen personally a video of him, absolutely normal. Today he has no single weakness. So we have done that in the past. That is one thing. So this is regarding the endovascular procedure. The second thing is that as an expert, we have the choice to use dual antiplatelet or heparin. Absolutely, we can use to our choice, because you have crossed a level where you know when to use and when not to use. The weapons are at your disposal. But when there are viewers across in this forum who have, in the practice stage, and those people are the students who have joined, we have to put a different views also. For example, they shouldn't carry an opinion that NHS 21 I will use a dual antiplatelet therapy. It is off label. We can still use it, but dual antiplatelet with the NHS 21 will be difficult for the routine management of stroke. I think you would agree with this, because the chance of hemorrhage would be high. But you were right in the retrospect, because the serial scans never showed a big infarct. So technically, whatever happened to the patient happened to your desire, but only to put across the statements of being on the right side of the law or the right side of the textbooks without going for the off-label use. NHSs I wouldn't have used. And we also do not use heparin routinely at all in these patients, because we have found it quite dicey. Hemorrhage risk is high, and when it is not supported by data, we'll be hesitant to do it. As I said, experts like you can do it. But for the routine management, maybe it is not so. And the key question to ask is, what was the deterioration about? How did the deterioration happen so chronically? I think there were some collaterals which were supporting him all the time. The collaterals are supporting him. And the failure of collaterals over a period of time was responsible for the worsening. Because if you look at the Hamlet data, the best timing for hemicraniectomy was actually 48 hours. That was the best timing. Beyond that, especially beyond 7 days, the data does not show any significant benefit with hemicraniectomy. That's what the data says. Nevertheless, we have the right to choose. If we believe that the deterioration was because of the progressive edema, we have the right to choose at that time. Again, it's a strictly off-label indication, but given the patient in our front, because ultimately you are the warrior who is actually fighting that war, we have a desire to take our decisions. I absolutely agree with you that you took the decision of hemicraniectomy. However, difficult it might suggest. Maybe you were looking at saving the life, because we were very sure at that point of time that neither the weakness nor the aphasia we could make a significant impact to. But definitely we were thinking about saving his life, and that was absolutely essential. Again, for the viewers, it is off-label. You do it beyond that, but in a given case, we can do it. The key question which you raised is, why did this patient deteriorate? One, was it a progressive cerebral edema? Or number two, was he throwing multiple showers into the brain from that chronic thrombus? And that is the reason why this happened. That is why Dr. Balakrishnan sir said we might use heparin for this patient to prevent that thrombus only. Or it was just failure of the collaterals over a period of time, despite the fact that some support was given for the BP, still it deteriorated. These are the three things in our mind. Whether midodrine is useful in this case, it is again an off-label indication. We don't have a recommendation for using midodrine. Frankly, I have not used midodrine in my practice. We use the routine, ionotropics to keep the blood pressure high, because there is a chronic occlusion. As Balu was telling, we need the BP to be little high. We use the routine inotropes. Maybe it's a good choice for you to use midodrine. There's nothing wrong in using midodrine, in my opinion. The patient had a poor outcome because the best agent was used. If you look at the data on these thrombolytic agents, the best thing which opens the large vessel is actually tenecteplase. We know that from the extend IA trial, that 10% of people who are put on tenecteplase did not go on to require even a mechanical thrombectomy. So the best treatment was given. So something was beyond us in this case, and that I feel is the reason for worsening. So finally, coming to that, number one, endovascular thrombectomy might have been considered by me. Number two, definitely we have the right to use dual antiplatelet as well as heparin, but understanding that it is off-label. And thirdly, however late it is, for saving the patient, we may have to actually do with what's that? Decompressive hemicraniectomy, because ultimately life of the patient will be important. And fourth, the worsening probably was progressive cerebral edema, plus was minus the repeated shower, and then the drop in the collaterals. This is my view in this. I stay with my opinion.
Thank you,
As you,
sir.
as you said,
Welcome. Yes,
as you
sir.
said,
Yes, sir. Yes, Narendra. Yes, sir.
as you said, sir, the towards the end, I was not very keen in hemicraniectomy also, even with the 10 mm midline shift, because I think after that time, I don't know what exactly we are going to change in the course of the disease or the course of the improvement. So, but once the midline shift went beyond 21 mm, even I could not convince the family to avoid the hemicraniectomies. Since the patient is a doctor, you know that there are multiple people involved and multiple
Very true.
opinions.
Very
So,
true.
and neurosurgeons'
It
opinions
was
and
one
all
of
those
the
things
poor
will be.
prognostic factors.
Yes, sir.
Multiple concerns. Yeah.
This patient made me feel uh, very low because we were not able to do anything different over the next 2 weeks, and continuously there was same thing going on and on and on, and it was continuously progressing. The patient comes to you versus within 2 days, it is very easy, but you see the patient for 2 weeks and day by day, 2 days, once he's progressing, it was difficult to watch. And patient being a doctor,
This
it was very
patient
difficult.
gave clue with very high NHS not correlating with the watershed small
Sure.
infarcts.
True,
That
sir.
was the
True,
first
sir.
clue the patient
True, sir.
gave to us. So one message that we can take from this patient is that the NHS was
So
very
high.
high,
Very
but
high.
the scan was very comforting
Yes, sir. Yes.
scan, reassuring scan.
Small
So
core, large penumbra.
I have
this
a
is
Typical
the
small
one.
core, large penumbra.
Yeah,
I
this is
had
the
a
Like what
one.
doubt.
was seen in the Dawn trial.
And I understand you did a repeat CT after 5 days. Is there any repeat CT after doing a thrombolysis?
It was there, sir.
Immediately.
It
Yes,
was
sir.
there. He
I
showed
didn't
that.
post it. I told no, sir.
Okay. Okay.
Within 2 days it was there, but even immediately after 24 hours after thrombolysis, we did a CT. It was not
Okay.
showing any large influx. I had a doubt in this question also, sir, whether this small influx is not correlating with the NIHSS, whether critical stenosis causing an hypoxia to the left brain can cause a transient increase in NIHSS. Once we improve the perfusion, the patient might have an improvement.
Hypoxia also related to hypoperfusion.
Yes, sir.
In my opinion,
This is
this
not
is
pure
a
hypoxia like what we
large
see.
perfusion defect, small core. We would
Yes,
have
sir.
done a perfusion study as well in this case to prove this. ASL at best, but if ASL is not considered accurate, even a perfusion study when
Yes,
we
sir.
are going to chart about DVT. This is a small
ASL,
core, large perfusion defect, I feel. More than hypoxia, as Balu said, I think it is hypoper. At that point, that's what we would have considered actually. This is one of the critical, mismatch of perfusion defect, I feel.
That
And
was
as I
based
said,
on patient's progress.
yes, sir. Yes, sir.
Actually, there's a matching only, matching with the patient's deterioration.
Yes, sir. So
That is what we expect. There's the one
we
clue
see,
that
yes, sir. Even though the patient scans worsened slowly, and the patient was not showing a lot of worsening for the first 2 weeks. It was the same present at the day of presentation, but we keep doing CTs and the influx slowly progresses. I think it is already, I mean, maybe histologically or metabolically, it is already gone, and then the scans are showing a little later. That's what I thought during the course of the disease. Because the initial NIHSS and the NIHSS at the end of 7 days was not much of a difference, even though the influx were progressing very fast.
true. This is a difficult case. Even if EVT would have been done, maybe there could not have been a successful perfusion. This long occlusions notoriously very difficult to open, absolutely difficult to open, especially in those formative years when we started doing this. It was the toughest. And one of our patients, we put a stent there, and still he thrombosed inside the stent.
Okay.
So those things before these recommendations came, we have tried all that in the past.
Okay.
Even if you look at the hemicraniectomy, when I joined Apollo, we at the time the indication was not like this. You can't do it like that. The recommendations were not so easy. The patient has to deteriorate. At the time of deterioration, we should do it. So we have to actually do the pupil size. When the pupil size becomes smaller compared to the contralateral stage, that is upper midbrain stage of the transtemporal herniation, and then you have to do it. So we devised a pupilometer with a small, cardboard we used to divide, and the sisters have to be taught to look at the pupils. A larger than usual pupil is easy to pick up. A smaller pupil is never easy to pick up. So we used to miss that. And then at the time, Dr. Arun was with me. So I told one night, one of the cases when we lost, we had really, we sat and I was almost in tears. At the time I told Dr. Arun, sir, henceforth we will forget about this. Young person, large infarct, just take it out. Believe me, we have done on day 1, leave alone day 3. Patient admitted, at the time only 3 hours window, not 4.5. This was before ECAS 3.
Okay.
First day we have admitted, we have done that. This is the extent of aggression we went through after losing a few cases. And then came the Hamlet, and then the Decimal, and then the Destiny. All those trials proved that we were doing the right thing in a young patient. Old patient after 72 years, I would have waited. I wouldn't have done that on first round. This is a bad case overall. Age was more, NHSS was more. There was a chronic occlusion. There were so many things which I feel it was against the patient. And there was a progressive deterioration. So it is a destiny. Very well presented. Thank you very much, Narendran. I think we will take over to the next case if Balu and Balakrishnan sir are ready.
Yes, Balakrishnan is busy with some other works, and thank you, Narendran. Wonderful case.
Thank you, sir.
And I worked with the senior neurosurgeon. Whenever the case is not coming out of the surgery, he consoles me that the patient already decided to die. So that's the way that he consoles me. So
Absolutely.
sometimes it happens. So
Brilliant, Balu. Brilliant as usual. Correct.
I learned from the neurosurgeon. So
Absolutely.
Sir,
Thank
sorry
you.
to interrupt. Shall I leave, sir? I'm with my family.
Sure.
Shall I leave?
Have a
yeah,
nice
No,
day.
yeah.
as sorry,
It's
sir.
Saturday
Sorry
night.
to.
Saturday night at Goa. Sorry for disturbing you.
Adilla Balu, go on
Okay,
to
sir.
the family.
That is
Some
which
suspicious
family you
words.
didn't ask, right?
Anyway,
You
thank
can
you
Yes,
have
very
a
sir.
much.
lot of
Thank you,
family,
sir. Thank
academic
you, sir.
family,
Have a
Thank you.
nice
non-academic.
family, you mean, but have a nice
Yes.
time, whatever it is.
Yes,
Thank
sir.
you.
Thank you, sir.
Madam, let us invite Madam for the
You
talk. Madam, we
should
are
be
waiting for your
should
talk.
be
Thank you,
fine.
Narendran.
SMS you should be fine of conducting a Saturday night program at 9 and Balki at Goa. Thank you for
Balakrishnan sir should decide to stay in
Narendra, it's a
Coimbatore.
very wonderful case and really
Balu,
eye-opening.
you have echoing, Balu.
Echoing, sir.
நீங்க 2 டிவைஸ்ல கனெக்ட் பண்ணிருக்கீங்களான்னு பாருங்க. And now
Now
just
it's
stop.
okay. Now it's
No,
okay.
I'm not. Somebody else.
Okay.
So,
Somebody was echoing actually. Yeah.
yeah. Okay.
உங்க word
I
அவங்க echo
echo
அடிக்குது.
your voice only.
I'm telling you really. So I think we should now call. Thank you, Narendran. Thank you.
Thank you, sir.
Let us move on to Madam. Madam, your stage is
Sir,
yours.
again, it's again happening.
Thank you, sir.
Again echoing. Somebody has joined with 2 devices. So one of them has to be taken out.
Sir, am I audible, sir? No?
Yes,
Madam,
madam.
you are audible, but we are having. Are you connected to 2 devices, madam?
No.
You
I'm only
connected
connected
phone as
through
well as
the.
the
No.
phone and
I'm,
the
no, sir. I'm connected only through the laptop.
and your phone.
Phone is. I'm not connected.
No,
Through
no echo. Hello.
Hello.
It's clear now.
Okay.
I request the organizers to look into it. Maybe you mute everybody, please.
Sundar, you are echoing.
No, but I have only done in one voice. No.
Nankishore, can you just look into this because I am
Except
also
the speakers, all others can be muted.
All of us will be muted. Madam, yes, madam.
First of all, good evening, esteemed distinguished senior neurologists, and it's my pleasure to present here, and very nice to meet Meenakshi Sundaram sir after a long time, sir. And this is actually a case of confusion, basically, whether to thrombolize or not. So this patient is a patient who is in his 60s, a 68-year-old male, who is a known case of carcinoma buccal mucosa, who underwent composite resection and with microvascular free flap 3 months ago. In the sense that this patient came, because I work in a place where it is basically a cancer care center, and they have performed this surgery exactly 3 months 1 week. The duration with which he presented is 3 months and 1 week. After that, he has presented to us with this history of sudden onset of left upper limb and lower limb weakness with mild dysarthria, and with a history of duration of 1 hour, On examination, he was conscious oriented, and pupils were reactive to light with pulse rate of 76 and blood pressure of 150/80, and ECG was normal, and temperature SpO2 was within normal limit, and 2D echo was also normal. And when we did the NIHSS, the thing is, because he underwent a composite resection, already he had a mild dysarthria, and the attendants were not sure whether this dysarthria was a new onset or a previous onset. So if the total NIHS excluding dysarthria was coming 4, and after including dysarthria it was coming 5, and when we took the MRI, it was obvious right MCA territory infarct, and with the DWI ADC mismatch with no flare signal. So our main confusion was, with all these comorbidities, whether to thrombolyze this patient or not. So the dilemma was whether it's a major recent surgery, though it's a non-CNS surgery, it's a major surgery with cancer with more tendency to have bleeding, and borderline NIHSS, and unknown metastasis. The PET CT was done 3 months back when he underwent the surgery, and attendants were very resisting the thrombolysis because of the age, as well as the 3 months back itself he had undergone a major surgery for cancer, and now it is stroke, and we are explaining to them about the pros and cons of thrombolysis, and by the time the MRI got over, already 2 hours was over. They were not even willing for MRI. It's a difficult situation when it comes to a stroke with the underlying malignancy. So we thought of going ahead with thrombolysis with the tenecteplase, though the dose chosen was 0.2 milligram per kg. Because of the underlying malignancy, I did a low dose thrombolysis actually, and it was I cannot say it was a non-disabling mild stroke, but the patient had, on presentation, the power was 3/5, but as after MRI the upper limb power did drop to 3-. So we were not sure whether there was fluctuations, and there was a lot of confusion around this thrombolysis, and so the dysarthria, our attendants were telling it has increased recently. One attendant is telling it is not, this is the same. So, and the facial asymmetry also we were not able to make out, because it was a microvascular free flap, and composite resection was done recently. So finally we went ahead with the decision of thrombolysis, and meanwhile we also did the CT angiogram, and this thing which showed no large vessel occlusion, and ECG was not showing AF, and echo was normal as earlier mentioned, and we went ahead with the thrombolysis based on the guidelines. But our case analysis was like, surgery was 3 months ago, that to 3 months 1 week exactly, and the surgery was done in the head and neck territory, and free flap reconstruction was done. And these are the points which we took as a pro for the thrombolysis, because the free flap reconstruction would have healed by this time, and the operative site is distant from the neurovascular territory. And neurosurgery only the guideline phrases as 14 days to 3 months as a relative situation requiring case by case analysis, and our decision was based on 3 months post operative acceptable risk given disabling stroke, because it was a progressive stroke. So we thought, we also consulted our oncology team, and they were of the opinion to take the decision on they are more of opinion that we should take the decision, and from their side they were like, the malignancy, the bleeding tendency is unknown, because this patient during the according to the surgeon, during the surgery, patient had blood loss, and he was given packed cells and packed RBCs and all, it was given. So we were really in confusion whether to go ahead and thrombolyze with 3/5 lower limb and 3-5 in the upper limb. So finally we went ahead with the thrombolysis with arguments for non-disabling was the dysarthria is mild and patient could still communicate, and motor power was 3-5. Then for disabling stroke is he cannot use the limb for functioning, and dysarthria affects patient's profession because he is a person who works in office and lot of with the clients and all. He used to work earlier, and he has apparently resumed his duty after 2 months of this surgery. So, and also the guidelines in 2026 says NIHSS alone should not determine the eligibility, and disability should be given the importance. So, and over all this, the biggest confusion was from the attendant side, because patient has cancer. Why do you want to give a dangerous medicine? He had just surgery. Whether the flap will bleed, or whether it is he is fit enough to take the medicine. This question we keep getting in cancer patients, because they feel once the cancer has affected the body, everything is gone, and they are not willing to take even the chemotherapy post surgery. And brain bleed risk, when we explained it, even added to the fuel, and they were not at all willing for thrombolysis. And then we discussed with the two major attenders, and then ultimately they gave the consent, and we went ahead with the thrombolysis. And there was no post monitoring. There was no hemorrhagic transformation after 24 hours. There was no new pupillary changes or BP spike or new headache. And during the discharge, after 10 days, the motor power had improved in the upper limbs as well as lower limbs, and dysarthria was almost same, but we can say little reduced compared to the admission. And hospital stay was for 1 week or 1 week, and but the assessment I have written is after after 10 days of the discharge, and he was ambulatory after the discharge. So this is, we already know this IHA ASA table for thrombolysis classification. So what we have learned from this case is like NIHSS is not the only thing which decides the treatment decision, and surgical distance matters. And when we look into the guideline, malignancy, they tell it is a individual consultant decision, and as discussing with the oncology team, you have to take the decision. And relative and absolute contraindications are important, but in our case it was like 3 months 1 week, so that also made us little confused, and we gave the thrombolysis after 4 hours of presentation actually. And there was a DWI flare mismatch, so there was an indication for thrombolysis. So what we would have done differently was I felt that we did MRI first, and then we little time we spent in counseling. Then they were not willing for CT angio. Why just now you have done the MRI, why you want to do CT angio again? All these things happened in the ER, and it was the scene itself was like many half of the team of attenders were willing, and half of them were not willing for the investigation also as well as the treatment. So take home message from my side is individualized thrombolysis, relative contraindication should be weighed, and disabling deficit should be determined based on activities of daily living. And tenecteplase place is now the preferred choice, and DWI flare indicated that it is hyperacute infarct, and good consent is not a barrier. It's a clinical key which can help in saving lives. So I thought, it's already so much discussion has been done, so I thought I'll quickly finish it, sir.
Thank you, madam. Thank you for the nice presentation. I've known, adult neurologists, pediatric neurologists. First time I'm hearing, cancer neurologist.
Malignant neurologist.
Never knew such a thing.
You can call him malignant neurologist.
Malignant neurologist.
No. So no. In this case, the patient was not a diabetic, not a hypertensive. Neither he had any risk factors for getting oral buccal mucosa cancer. In the sense, he was not a smoker, not a tobacco chewer. We do not know how what is the reason for his CA buccal mucosa, and all the CT angio was negative, ECG 24-hour Holter, and everything was not telling us what is the reason for stroke. Then ultimately I attributed it to malignancy as a risk factor for stroke, but usually the malignant strokes will present in the multiple territories, not like a single territory. But still I'm not sure what is the reason for stroke. We have not done the transesophageal echo, but still very unlikely that transesophageal echo is indicated in this case.
Thank you, madam. Let's take views from Dr. Narendran. Narendran, your views on this.
Sir, mine is, was the patient, did he receive neck radiation for the
I think you are having a lot of echoes.
lot of echoes, sir.
Patient did not get any neck radiation actually.
Can somebody mute everybody's and then again restart? All of us, let us mute ourselves, please.
Nankishore, can you just address this issue? There's a lot of echo from everyone's end actually.
Yeah.
Can you
now
just
I
look
think-
into it?
Now it is fine.
Now it is fine perfectly. Somebody was actually having two connections, I think.
Yeah.
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 Narendran, you can give your views. Thank you.
Sir, I think I would have done a thrombolysis. I think since the infarct was on the largest side, one thing I was thinking was whether the patient received a neck radiation for the buccal mucosa, which can cause atheromatous changes, or it can cause stenosis in the ICA. If it is not there, then I think I think again still thrombosis maybe the prothrombotic state may be the next favorable cause because of the presence of cancer. As you said, usually it occurs in multiple territories, but the nature of the capsular ganglionic infarct, we usually see that kind of infarct in cardioembolic strokes. That's what I thought. The moment I saw the infarct, I thought it was looking like a cardioembolic stroke where you have an MS and MR which throws a thrombus, and that's what the usual picture is. I think the pathophysiology must be a prothrombotic state when there is a buccal mucosa cancer. And I think thrombolysis, doing thrombolysis is, I mean, I think it was straightforward because it was more than 3 months. And explaining to the patient if they are willing, I think we should have gone with it. Since the delay is from the patient's side, I think we cannot do anything. But we have never seen a lot of bleeding with thrombolysis, especially tenectic place. And even though the surgery was 3 months before, I don't think bleeding was going to be the problem here. And thrombolysis, I think, was a straightforward answer. So I think it was done. Again, it started.
Okay, I think I have not opened two stabs. I opened only one tab.
I think again the echoing has started.
No.
From this one, please, organizers, please again address this issue urgently, please.
Actually,
Dr. Shruta, Madam, could you address this once again with your team?
Yes, sir. Nankishore, can you just look into this again and info? I'm also having it.
I'm also getting.
किसी ने दो डिवाइस में कनेक्ट किया होगा सिंगल में दो
Please mute everyone.
Yes.
Yeah.
I don't know whose problem is it. Suddenly stop.
Balu, taken over, please.
Presentation, as Madam rightly said, that there is no absolute contraindication. The recent guidelines also has discussed this issue, and it is not an absolute contraindication. Of course, so we are much worried about the platelet count and DAC status sometimes. And we can explain to the patient, and then we can do, if there's a large vessel occlusion, straight away we can go for mechanical thrombectomy rather than going for. But that's not the case in your particular scenario. And I agree with you that whatever said, and then the non-disabling is disabling for X, non-disabling for Y. So every non-disabling has to be considered as a disabling from patient perspective and our perspective also. And I think that the malignancy produces multiple is right. If it is more than the 3T phenomena, more than three or more than 3 territory, it's most likely embolic source of cardiac, or if cardiac is not there, it's most likely malignancy. But even here also multiple showers of emboli, still it could be possible about the malignancy. So it can start with the one area and then it can spread to the other area also. Recently, Dr. Divya Selvaraj presented one patient had a testicular tumor, and that was a drug-related chemotherapy-related thrombosis, and she thrombolized, and then successful outcome had come there. So there's another patient. In our no thrombosis forum, we discussed 6 months before SMS.
Yeah.
Hope you remember.
Correct.
So
I remember the case.
So these are the tough patients that we should discuss here, because no clear guidelines, but as you rightly said, that you have proceeded with. And is it really 0.2 mg is called low dose, or?
No. Even the 0.2 I have given. In that the total comes as 14 milligram. I have given 12 milligram. So I just told it is like low dose. 0.2 is our recommendation, sir. Indian recommendation.
Yeah. So,
Madam, I have certain points to give. The first thing is that, Madam, we had an argument here on many occasions as to what is to be done first. Should we do a CT scan or an MRI scan? And myself and Balu, we are always at crossroads in this. I am a person who always does CT scan within 3 hours. Absolutely, I don't go this. Balu says it should be the freedom of the person who is treating, which is the correct way. All always says people should be able to choose, and he gives practical reasons for this. But somehow I've been pushing the CT. Here is one exception where I have never done the CT or only MRI. Because if there has been a metastasis, as you correctly pointed out, we did not know the metastasis. If there was an intraaxial metastasis, it would have been a straightforward contraindication for. That's why I've never done that. The second thing is that a surgery, when you look at that, after 2 weeks is what the recommendation, as Balu was pointing, only 2 weeks. Beyond 2 weeks, whatever surgery, especially 3 months, everything would have healed. So I do not believe that there is any contraindication in this patient. And cancer by itself is never a contraindication. So I would have gone, unless we are, especially it is a solid cancer. So solid cancers by themselves, I do not believe it's a contraindication. And what is the mechanism it could be, as you said, it could be a hypercoagulability, the Trusher syndrome, rather than the D-dimer estimation. That would have given me a clue. Was the D-dimer estimated in this patient? Was it elevated? If that is there, then it would have thought,
no, sir. D-dimer was not elevated.
Then maybe that doesn't, because other than the cancer, that's what we would actually thought. D-dimer elevation is what we would have been looking at actually in this given patient. And as I said, hypercoagulability and non-bacterial thromboid, because malignancy can be associated with non-bacterial thromboid. What is it? NBT is one of the indications to look at the NBTs. That's what I would have thought in this patient. So these are my thoughts. Otherwise, I think we would have done the right thing. I would not have gone for low dose and all, but straight away full dose only. But I'm going to share two important wisdoms or, nuances in practice. Earlier, when we started our practice, 2001, 2 and all, extensive counseling. Extensive, I used to sit and counsel 30, 40 minutes, believe me. So you can understand our dilemma in that patient. I'm talking about 2001, 2. And nothing worked. Today, our counseling does not exceed 1 minute. And it is a 100% success rate. Because I have understood that the lesser you talk and tell them, because you are doing the right thing, they will take it. They think that we are desperate to give injections to them. And I use one beautiful example and tell you who has taught me. So I'm going to give you this example which you can use in your practice. I've used extensively this, but it is written from in a beautiful book. It is written. I'll tell you this. When a patient is, willing or not willing, this is what I say. Your house is on fire. You are the fireman who enters. So the fireman comes and this person is sitting and saying, sir, you must come and put out the fire. My house, I have kept important documents on the third floor on the right side. I kept all my money on the left side room in the second drawer, and all my important cloths are there, certificates are there. You must save all of them. And when you leave, the house should be the same as you entered, as it was before. So what will the fireman say? He will just say nonsense and he will leave. So this is an example I have always used in my practice. Your house is on fire, your body is on fire. We are coming to let out whatever saves is saves. And this beautiful quote is written in a book called Stroke Pakkavan. The name of the book, Balu will tell, and the author is our Balu Murugan. It's a brilliant Tamil book, all of us should read. It is written in that small page contains that one paragraph. And that example, when you use, hardly ever you will fail. Absolutely, the patient will be willing. And the second thing which I learned in my practice is that when you say there is a 6% chance of hemorrhage and all those things, then an acute praise. They do not understand this. You tell them it's a 50-50 chance, shall we take it? The acceptance rate is almost 100%. 50-50 is much better than 6% hemorrhage. Believe me this. You will see this in practice. So these are certain things which go beyond our medicine, which I have learned from experts like Balu. So you can use this in practice, madam. We'll always be successful because we are not dying to thrombolize. It is after all for their sake. They have to accept. They don't like it, it is fine. We go house and we start watching our television. That's all. They have to decide. If you have that attitude, the acceptance will be 100%. Balu, your thoughts, Balu? That's
Yes,
brilliant.
Samas. If they are not willing, they have to sign it. If they are willing, it's automatically. If you are not willing, sign, put the signature. That's all. If you are delaying the MRI or scan, we will discuss and then put the signature. That's all. So that will
The
make
same
them
time, document the time. Always document the time. You tell them at 7:20 I have spoken with you. 1 minute, 1.9 million neurons. You take the call. I have documented the time. The time is yours. The second person will not come and ask you, believe me. Because unless they think that we are the decision makers, we will call our uncle. Uncle will talk to somebody in US. All these things have happened to me. They have to call somebody in US and they have to take their concern. Because now thrombolysis is so much common. You have to believe 2001 to 2 I'm talking about. Very difficult. So all these things we tell them nowadays, we tell the time is yours. 1 minute, 1.9, any number of neurons die, because then they will ask, what is the amount of neuron death which is possible? As if we can understand that 5 minutes, 1 crore. Whatever we accept is possible. They'll absolutely accept. 1 crore neuron will stun them. Because they put nowadays all these chat GPTs available, they'll give the information. They will 100% accept, believe me. Don't worry too much about it, madam. Anyway, wonderful case. And the 0.2 milligram is good enough, I think. And the truth is that we use the correct agent, correct agents, and the patient became better. What more we want finally? Tell me. The patient became better after we gave treatment. And that is a proof of the feeding.
Yes, sir. The thing is, this other stroke patients we don't
Madam,
find.
I think you are connected to Wilson, madam. Your only voice gets us. Put off your phone, madam. Put off your phone in flight mode. It will work.
Okay. I did that. I put it in aeroplane mode.
No. Yes, madam.
Actually, sir, the other stroke patients we don't find difficult, but this patient had undergone recently surgery and they have come with some problem with, like, from 15 plus attenders, because they have already visited our hospital for surgery and now they are coming with another. For them, they don't know all this, right? So they are like, recently we have spent so much and now you are asking me to. This is the thought process they always have.
Absolutely, madam. Let the decision be theirs.
Yeah.
What I'm saying, that is their father. They have to decide. You tell them what it is. That is all. This much is cost. You are not taking that money, right? The injection is not ours. You can let them decide. If they don't want it, we are also comfortable about it. But document it. Write it down, as Balu said. Get their signature.
Yes.
Let them sign. In our hospital, in the foyer, we have a camera. The first thing I say is, you take your phone and record whatever I say. Narendra knows. They will record my talk. After that, I say, it is with you. You go and convince your attenders. 1 minute is equal to 1.9 million neurons. I tell that to them. And I tell them, look, I have a recording of yours. And I tell the timing also purposely. It is 7:21 p.m. Please understand that. Now you make a decision and come. You can see the camera there. It is recorded. Their decision will be done in 5 minutes. Less than 5 minutes, they will come back to you. Sir, please give if they want. They genuinely they don't want, or they don't have money, they won't do it otherwise. But there will be no blame game after that. Because they should be told that we have also recorded it. That is the one that gives them leverage. Because anytime they can say anything they want. No, it was not told to me.
Yes, sir. We give this counseling in a video counseling room only, where we have video and audio.
And tell them the time there.
Yes. We're doing
9:22 p.m. I have told you 1 minute, 1 point. Take a decision.
Yes.
Anytime you can come.
Yes.
They will absolutely come back, madam. Believe me. And use Dr. Balanmurugan's example. I shared this on many forums.
Sure, sir.
Yes. Any other cases? SMS? Only 2?
Absolutely. So this is a case of
Both
cancer
cases are wonderful
embolism.
cases. Thank you.
Socia.
Hello.
Yes, Balu.
And final words from the jury?
No final. You give the final words, Balu, and we'll close.
That's wonderful cases.
Narendran, any words from you?
No, sir. I think Madurai is seeing easier acceptance because of your works, I think. Because we never get no for thrombolysis. Maybe for thrombectomy, but thrombolysis here nobody says no. It is a decision within. In fact, they come to us asking whether we can give thrombolysis. So probably your works and other people's works has made it
Not at
easier
all.
for us.
Balu, we have gone to Narendra. We have gone to every small city you name around Madurai. I have gone and given talks. Talks at they put the time as 8 o'clock. The talk starts at 11:40 p.m. And I stayed there to talk only this. So that is and it took 2 years for me to do the first thrombolysis.
I think that's why it is
Not so
easier
easy those
nowadays.
days. Any other comments, Balu, before we close?
Wonderful sessions on this Saturday evening. Thank you, madam. Thank you, Narendran.
Thank
so, being Narendran
Thank
at
you,
a long
sir.
time. Forum. Thank you. Keep coming.
Thank you, sir.
Madam, keep coming
Thank you,
back.
the host also.
Eye opening.
Dr.
Knowing more
Sridhar,
and
madam,
more
thank you
knowledge.
very much. We'll thank the host also and then we'll close the session. Thank you very much.
Yeah, thank you so much. I would request Deepa ma'am, if you can just mute yourself, that would help. Yeah, thank you. I would request Kutti Krishnan to propose the vote of thanks.
Yeah. Good evening, all. And on behalf of Gennova, as usual, and as always, this was one of the wonderful sessions which we had, and it was the best way to close a weekend. And thank you, SMS sir, for a wonderful chairing this, coordinating this entire thing, and Dr. Balamurugan sir and Balakrishnan sir for moderating this session. And we had two wonderful speakers today, and the cases were like pearls, like Dr. Narendran sir and Deepa ma'am. So thank you all for giving us one of the insightful weekend with this KT. Thank you and good night all.
Thank you, sir. Thank you all.
Thank you.
Thank you.
Thank you, sir.